Today, the last thing we'll get to will kind of be a take on this louder than a bomb theme. I was debating whether I should make this the Public Enemy song "Louder Than a Bomb," but it was easier to find the movie poster for this one. So we'll get going and talk about a couple of things, updates in science first. So an article that came out last week in Nature Medicine, which got some attention in the press, but thought it was worthwhile in discussing, was a large study from the U.S. Veterans Administration Health System, looking at long-term cardiovascular complications in people who had COVID-19. So these folks from the St. Louis VA took, oh, hold on. Sorry, I threw this out of order. That was the wrong, the wrong journal article title, but we'll get to that next. The first one I wanted to talk about is actually a study that looked at household airborne virus detection. I'll go ahead and fix that journal title for the slides that we distribute to make sure that you have the reference. But this was in I think PNAS. Dang it, sorry, can't remember which journal this came out of. But looked at virus detection aerosol in houses of index patients with COVID. So this looked at 11 patients. You can see on this first table on the left, and it describes the testing characteristics of those patients. So those numbers there in the N gene or F1AB and S gene are from PCR test with a 3 target PCR. And those are cycle thresholds, or how many cycles of PCR amplification it took to get detection of virus. So the lower your CT value, the more virus is present. Anywhere in the teens and 20s is a significant amount of virus, and certainly at the level where we think those people are potentially infectious because they're shedding large amounts of virus. And you can see that all of these patients were shedding virus in a relatively high range. Certainly the ones in the teens, you see patient number 2 and patient number 9, very low CT values, which means lots of virus. And then you see the number of household contacts they had there, and whether there were other reported positives in the house. And you can see for most of them, there were positive contacts in the house, about half or a little more. But you also see that in some instances, where you might expect there would be positive household contacts in people who have very low CT values, that wasn't always the case, as in patient 9, who had CTs in the teens, which is again a lot of virus, and a cough, right? So you'd expect expelling a lot of virus particles into the air, but not necessarily, but no household contacts who had a reported positive case. And then on the right in table 2 are the results of air samples from within their house. So good gravy. They had sampling done both in the isolation room itself, so the bedroom where the person was being isolated in the house, and then also in essentially the family room or common room, obviously remote from where those people were. And what they found is in a significant proportion of those common rooms, as you can see, in 6 of those, they had detection of airborne SARS-CoV-2. So in a little over half, right, of the households. Now, again, it's interesting that it didn't always correlate with folks who had the highest viral titers. So again, point you to patient number 9, who actually did have detection. But when you look across all of the rest of the data from patients, it was not always the people who had the lowest viral titers who had detection of virus in the common room. Again, a couple of the folks who were in the mid 20s and low 20s did not. So a couple of things to take away. First of all, that virus was detectable in the air in not only isolation rooms where these people were being isolated with illness, but also in remote rooms in the household. Should not be surprising, but confirms, I think, what we've discussed about the transmission of this virus and how it is primarily airborne, and that airborne transmission can occur over significant differences. And that's why things like ventilation and maximizing air exchange and having HEPA filtration in houses is so important to be able to mitigate the risk of transmission. The other interesting fact is, again, that even though people may be shedding higher amounts of virus, and even if it's detected in common areas, doesn't always translate into transmission. And there's other factors. And we know this from some of the studies that point out the phenomenon of super spreading events and the high dispersion factor in transmission for SARS-CoV-2, where the vast majority of people who are infected actually don't infect other people, but it's a small proportion of folks who end up infecting others. So just thought this was an interesting bit of data that, again, reaffirms what we've known. The second study I wanted to talk about was this study from the VA of long-term cardiovascular outcomes. And again, this is from folks at the St. Louis VA and WashU, and they took a large cohort of over 153,000 veterans who had a diagnosis of COVID-19. These were inpatients and outpatients, and then developed two control cohorts, a contemporary, so from the same time period, over 5.6 million, and then historical over 5.8 million, and looked at the incidence of cardiovascular disease events in these patients greater than 30 days after their initial infection, and compared it to controls. And what you can see is, for both the contemporary and historical controls, they had a much higher incidence of all of these different cardiovascular disorders greater than 30 days out from their initial diagnosis. You can see across the board a much higher incidence. Interestingly, myocarditis, much higher incidence in folks who'd had a diagnosis of COVID-19 compared to those controls. That was the highest correlation in terms of increased hazard ratio, as you can see there, but other things like cardiogenic shock, pulmonary embolism, thromboembolic disorders, you can see at the bottom, all increased compared to both controls. And this was true across all of the different comorbidities and demographic differences. So it makes the association seem a bit stronger, because it's not just potentially factors like other comorbidities of age or race or smoking, obesity, hypertension, all of these things. Those relationships bore out in terms of an increased hazard ratio for folks with COVID-19, whether or not you had these risk factors. And so this looks like a more convincing association that having a diagnosis of COVID-19 increases your risk of all of these. And that seems to correlate with the severity of disease, which also makes it a bit more convincing. So if you look for folks who are outpatients or non-hospitalized, most of these associations still hold true, although some of the more extreme, such as incidence of ischemic heart disease, cardiogenic shock, and cardiac arrest, don't seem to have any increased correlation for those who had mild cases of COVID-19. But some things, such as dysrhythmias, inflammatory diseases of the heart, as you can see, myocarditis, a hazard ratio of greater than 3, even if you had only mild disease that didn't require hospitalization. And then as you increased severity of disease. So hospitalized patients and then patients who required ICU hospitalization, all of those have dramatically increased risk of these various cardiovascular events. So seems to be pretty convincing evidence over a large population. Now, it is a veteran population, so it is in general slightly older and certainly a lot more male than most of the general population in the U.S. But I think shows pretty strongly that at least in that population there's a very close association between COVID-19 and subsequent risk of things like thromboembolic disease, myocarditis, and other cardiovascular complications well after the diagnosis of COVID-19 and the resolution of acute infection. And then the last thing I wanted to talk about was an interesting article that came out in PNAS. And this actually came out in June, I think. So a while ago, I had just missed it at the time, but I thought it was an interesting scientific study of the total number of SARS-CoV-2 virions and the total mass of virions that exist across the globe. And you can see these scientists took, essentially autopsy and other clinical data studies looking at how much virus was contained per mass of tissue, focusing on the lungs, but also expanding to look at other tissues and the lymphatic system and digestive system to kind of calculate how many virions are present in a person who has SARS-CoV-2, and then extrapolated across the entire population of the globe to think about how many virions are present globally at any given time and what would be the mass of those. And just a fascinating exercise to make this estimation. And so based on this, and again, these data are from kind of the peak last year, which is probably lower than the peak of the number infected with Omicron. So maybe this is a slight underestimation by twofold or so. But at any rate, they estimate that at any given time on the globe, there's anywhere between 1/10 of a kilogram to 10 kilograms of SARS-CoV-2 virus collectively across the entire globe. Now that is pretty amazing to think about, that maybe 10 kilograms, which is around 22 pounds of virus, are causing all of the disruption, all of the death, and all of the morbidity right now for SARS-CoV-2, for the COVID-19 pandemic. And that will be the instigator of all of the cases that come afterwards. So if you think about the collective power of that, the mass of plutonium in a hydrogen bomb is around 10 kilograms, depending on the yield, I think, for a half megaton bomb. So the most powerful weapons on Earth requires about 10 kilos of plutonium. This is equal to that and has caused death and morbidity on a scale way beyond what any single bomb could do. So that was the origins of my louder than a bomb analogy, and just kind of interesting thing to ponder when you have a couple of seconds about how 10 kilograms of virus can change the world. And that's all I got. Thanks.